Assalamu alaikum, everyone, and good evening to people who are from around here, and good morning to those who are far away from us. I'm delighted to welcome you all to the 4th chapter of the MENA Stroke Organization Educational Cerebrovascular Grand Rounds. This is an activity that's endorsed by the World Stroke Organization and the American Stroke Association. And these webinars provide a platform with regards to stroke management and its latest treatments. Today we have 3 speakers, Dr. Saeed Zahrani, Dr. Ashfaq Shaib, and Dr. Fahad Al-Ajlan, who will be talking about virtual stroke care. Each presentation will take about 20 minutes. And at the end of all of the presentations, we will have a session for questions and answers. I would encourage everybody to either write down your question or you can ask verbally if you want more clarification, but we will do all of that at the end of all the lectures. The first speaker, Dr. Saeed Zahrani, is a consultant vascular neurologist and the head of neurology department at King Fahad General Hospital in Jeddah, in Saudi Arabia. He is also the head of the virtual neurology department and telestroke lead at Sahha Virtual Hospital, and the director of neurology training program in the Western region of Saudi Arabia. Dr. Saeed is a member of several committees and has participated in many clinical researches and publications. Dr. Saeed will be talking about innovation in stroke care for 20 minutes. Welcome, Dr. Saeed, and the floor will be yours now.
Thank you very much, Dr. Abdurrahman, and I would like to thank the organizing committee and MENASO for giving me this opportunity to present today. We just heard that tomorrow is the first day of Ramadan, so كل عام وأنتم طيبين والله يتقبل منا ومنكم الصيام والقيام. May Allah accept all our deeds and help us in fasting of Ramadan. My topic will be on the innovation in stroke care, and as you all know that stroke is the second leading cause of death worldwide and is the leading cause of morbidity as well. And stroke is a major contributor to adult disability, with around 15 to 30% of disabled adults are secondary to stroke. And 87% of the stroke mortality happens in the low and middle income regions, and that is probably secondary to lack of the access to So the TBA is the most, or the thrombolysis is the most, by alteplase is the most effective treatment for acute ischemic stroke, and that treatment is time dependent. If we are giving it in the first 3 hours, the number needed to treat is 4.5, and if we are giving it in the late time window, the number needed to treat is 14. And giving that medication is associated with greater rate of independent and ambulation at discharge, greater likelihood of discharge to home, and there will be more patients will be independent, and fewer occurrence of ICH if we give it in an early time from the onset. But unfortunately, not all patients receive TBA. The rate was only less than 1% and up to 2,000, and then increased steadily. In our country, the rate is between 3 to 4% as well, which is secondary to the underutilization, which is secondary to public awareness, lack of stroke symptoms and signs, the geographical proximity to stroke centers, as there are many studies that shows if you are near to stroke centers, you are likely to get treated. But the far centers, they lack, unfortunately, they lack the ability to treat patients, and the narrow therapeutic window, as well as the complex diagnostic therapeutic decision making. As you know, the time is brain, and until 2015, all we have is in acute stroke is IV TPA. There were several constraints. One of them is the time constraint, which we can give treatment only within 4.5 hours. There are around 22 exclusion criteria that needs to be looked for. There are some of them are absolute exclusion criteria, some relative exclusion criteria, and it works on small and distal vessels, but work minimally on large vessel occlusion. And there were hemorrhagic complications as well with thrombolysis. And in 2015, the game changed. So with the publication of the largest thrombectomy trials, Mr. Clean, Escape, and Rivascat trials, all of those trials, it shows a significant benefit when doing a thrombectomy by endovascular mechanism. At that time, the system starts to change, and the treatment started to have different paradigm. So whether to treat patient in the primary stroke center and then shift him to a comprehensive stroke center for thrombectomy, which is a drip and chip model, whether we bypass the primary stroke center and goes to a comprehensive stroke center, and whether we treat in the ambulance and then shift the patients toward the nearest stroke center. So that leads to a complex decision making, and stroke care became complex, and that's secondary to a multitude of decision making that has to be made either in the pre-hospital setting or in the hospital, and where to take patients to which centers. In our country, we have as you know, the 997, which is the Red Crescent number, and 911, which is the unified emergency number that can direct you to the Red Crescent. You can call the ambulance through Tawakkalna app, which is everybody had it in his mobile phone, as nobody can mobilize without it. And there are another application which is called As'ifni, which means help me. That's if you just press the SOS message, it will goes to the emergency Red Crescent authority, and then they will send a help to pick you up. There are some first aid help in the application, which can be utilized to know at least what is the symptoms and what is the signs, and what to do as a first aid help. So there are several studies in the pre-hospital triage, including Direct MT, Swift Direct. Those are the trials that utilizing patients going to comprehensive stroke centers to receive a mechanical thrombectomy, and use a pre-hospital triage scale to shift the patients to the stroke centers. And we have a new app in the Red Crescent, which is called Musaf Electroni. There are several things into it are embedded, which is including the receiving the call, directing EMS personnel, working on the best track to take the patients to the nearest hospital, connecting the EMS and the ambulances to the emergency room, where they use what we call the Sahab, or the cloud applications, to know the expected time of arrival of emergency or EMS hospital. That is started in several cities. It started in Riyadh, in Jizan, in Taif, and in several health clusters in Saudi Arabia. We started it in Jeddah as well, which involves several steps since the start of the call until the end. But it has many people involved in the pathway, from the dispatcher, the EMS paramedic near the patients, to the EMS controller, medical director, where they will contact the Ministry of Health Emergency and Disaster Center, where they will activate the stroke code in the Preferable hospital. They did the fast ED to divert the patients, whether to a primary stroke center or a comprehensive stroke center, to receive the thrombectomy. But that message which will be conveyed from the paramedics to the EMS director, then to the Ministry of Health Emergency Center, Command Center, to the AR director, and then to the emergency room, it will be changed over time. As you know, the message, there was a human error into conveying the messages, and the final message will be distorted. That's why an AI technology needs to be interfered where it can take the message immediately, plot it into an AI analysis software, and plot the stroke centers into the stroke map, and then according to the criteria that is there in the score, whether to shift the patients to a comprehensive stroke center based on the localization of the patients and based on the past AD score. But again, the pre-hospital stroke scale have only positive predictive value of approximately 35 to 50%, which will result in improper delivery of patients with LVO to primary stroke center in about 20% of cases. There are several techniques that can be done. One of them is the Cerebrovascular. This is they use the volumetric impedance phase shift, which they will measure the difference between both cerebral hemisphere in terms of impedance, and they will recognize if this is a large vessel occlusion that most of the hemisphere is affected, or this is a small vessel disease or a small stroke that the patients can go to the nearby stroke centers. The other mechanism that can be used in the pre-hospital setting is the SONAS, which they utilize the TCD, but they need to insert micro bubbles intravenously, and the signals difference will rely whether it can give a detection whether this is a hemorrhagic stroke or an ischemic stroke, or there is a major vessel occlusion. The other way is using as well the neural analytic, which is a robotically assisted ultrasound device that uses TCD to TCD-derived biomarkers, and it detects if asymmetry between cerebral hemisphere in terms of blood flow through major vessels. The new innovative way is using the mobile stroke treatment unit to diagnose patients and deliver the care near patient's home. So the CT scan is built inside the ambulance, and the expertise will be contacted to give the reports on the CT scan and then give the advice on giving the treatment. It cuts the time from door to from call to receiving the medications by around 30 minutes. And the recent study, which may cause utilization of this on a wide scale from the Melbourne group, where they prove the economic value of mobile stroke unit, which result in an additional 30,000 per day of adjusted life year avoided compared to standard care, $30,000. The other disruptive technology, which is now being studied in a larger trial, which is an electromagnetic radiofrequency imaging. A very small device that you use the electromagnetic imaging, electromagnetic wave pulse, and will go into circles around the patient's head, and will give us this images. It's still poor images, but it can differentiate between hemorrhage and ischemic, and it can show if it is a large ischemic lesion or small ischemic lesions. And it's very small device that can be carried out into the ambulances and even to the wards nearby patients in case of critically ill patients. This is a conceptual design of an air ambulance where they will again built in a CT scan This is not yet being built, but is one of the probably near technology that will be utilized in emergency room. As you know, one of the major limitation of giving IBTBA is the geographical areas, and the patient that lives far away from the stroke center, they are less likely to receive the medications. And you know, there are some cities in Saudi Arabia or regions, they don't have the capability of giving thrombolysis. So that geographical area needs to be built out, especially in a country that is very, very large. It is not recent things. It was utilized in the American Civil War in 1961, where they used the telegraph to contact doctors and treat injured or wounded soldiers. And the first audio call was by a physician who listens to a child cough over the telephone. And the first video and audio consult was using an interactive television telepsychiatry consultation between two Nebraska hospitals using a closed television network. But the first use of telemedicine in stroke was in 1999 by Levine and Gorman, where they used a Telestroke system to contact a personnel to contact and connect video and audio call, and they use teleradiology to see the images and evaluate the images as far away. I will not go into details. This is one of our devices that we use it in our Telestroke network. And there are fictional drawer where they wrote a television that goes and treat patients, take vital signs, or insert IV cannula, which was drawn in 1967. That was like a dream, but it became true when the telesurgery was performed by Professor Jacques on 2006 transatlantic. So he was in America, and the surgery was done in UK. That's innovative technology leads to thinking why we don't do a mechanical thrombectomy to patients at their distal site. So a corneous device was invented. It's mainly used with the interventional cardiology suite, but it's used in one of the patients with brain aneurysm embolization, brain aneurysm treatments. And they use it in the same site, but one study they did 12 patients remotely. It removes the geographical barriers and workforce constraints. As you know, the interventional neurologist or interventional radiologist is very limited, and you cannot put them as well into small cities because they would have a low volume and they would lose their skills. So they are needed into large volume centers, as that volume or that centers will help in building their skills. It reduces the radiation exposure as well on the operators, but it has a high upfront cost. There is an issues with operator acceptance because the lack of haptic and tactile feedback that is used by interventional radiologists, and it requires initial setup at the beginning of the procedures. With this, I would end my presentation, and I would like to thank you very much for listening to me. And I would like to ask you to visit, if you have a recent visit to Saudi Arabia, to the southern region. This is an heritage city of Rijal Al-Ma in Hasir. Thank you very much.
Thank you very much, Saeed, for a very enlightening talk about innovation in stroke care, and for the brilliant ideas that you really presented. You have spent 15 minutes on your presentation, so we're good with time. Our next speaker is Dr. Ashfaq Shuaib. Dr. Ashfaq is the director of the University of Alberta Stroke Program, which in 2016 launched the first stroke ambulance in Alberta. He chairs the National Stroke Program and the National Residence Review Course, and he is on the board of the Canadian Stroke Consortium. He is very involved in clinical trials and has been in the steering committee of multiple acute stroke trials. Previously, he chaired the steering committee of large multicentral trials of SAINT-2 and CENTIS trials. When he was in Qatar, he started a clinical trial in patients with TIAs and minor stroke with 10 participating sites in the Middle East. During his time as Divisional Director of Neurology in the Department of Medicine, he started a stroke prevention clinic in Edmonton and also established a stroke investigative unit at the University of Alberta Hospital. Dr. Ashfaq will be talking about Telestroke that Dr. Saeed mentioned briefly at the end of his presentation. Dr. Ashfaq, you will have 20 minutes to talk about Telestroke.
Assalamu alaikum, and thank you for your kind invitation. Also, Ramadan Kareem to all my friends and colleagues who are listening in. Can you see my full slide deck?
Yeah, we do.
Perfect. All right. I also wanted to thank Dr. Al-Zahrani, who did an excellent job. So I will focus on two aspects. So he's already set the stage for me, but I'll dive deeper into what we believe is the current indication for telestroke as it applies to our region, and as well as the mobile stroke ambulance that we've been using for our telestroke. Just to remind you, we still have winter here in Canada. Hopefully it'll warm up soon. I have no conflicts with this presentation. So I'll spend a couple of slides, just a minute, on how sensitive is time for thrombolysis. I'll then go into rationale and our own Alberta model and our experience, and then talk a little bit about telestroke and the mobile stroke unit and how currently telestroke is becoming so useful during this unfortunate pandemic. These are the recommendations that if you're going to give TPA and be potentially a center that can also offer thrombectomies, you need to have an organized setup. These are the American Heart Association's guidelines, and you need to have a designated stroke team. And to give TPA, you need to at least offer TPA within 60 minutes to half or more of your patients, and half of these should be treated within 45 minutes. So pretty lofty goals. And the most recent data coming out from the US, where they've now collected data on more than 150,000 patients over more than 10 years, shows that these are attainable goals. So let me share with you this data from this got published a month ago, that if you look at the time, so from 2003 to 2018, and you look at the percentages of patients who are treated under 1 hour, you can see that about 15, 16 years ago, less than 20% of the patients were treated within an hour from coming into the emergency department. And that's gone up to 80%. So this is clearly a major achievement. And as you can see that in the 45 minutes group also, approximately 50 to 60% of patients now are being treated from the door to natal time is less than 45 minutes. So what has that done is that if you look at outcomes of disability, so a disability score of 0 or 1 means that they've now achieved an outcome that's almost as good as what they had before the stroke. So pretty high standard. This has gone in that 3-hour time window, has gone up from 17, 18% to 25% more recently in the last 3 years is up to 1 in 3 patients, so 30%. That is important. But to do this and to achieve these kind of goals, what do you need? You also need to have then a 24 hours, 7 days service that can attain these goals, where you can get to treat these patients very quickly. In our center, we are now achieving a door-to-needle times of 30-35 minutes constantly. We treat 300 patients with TPA. Monday, I was on call. We had 7 thrombolysis. 4 of them were in Edmonton in my hospital, and 3 of them I treated on Telestroke. So it has to be busy, it has to be comprehensive, and it has to be 24 hours, which I think is difficult to achieve. And that's where especially in smaller hospitals, so that's where Telestroke becomes very important. So just a reminder, this was already discussed by Dr. Al-Zahrani, that if you treat these patients within the first 90 minutes, then 25% would achieve a complete or near complete recovery. And as time goes by, you can see that this number starts to desaturate. So you're going from 27% to 15% recovery. Also, a harm, which mostly is hemorrhage, you can see is that as time goes by, the harm increases. Now, when we talk about 90 minutes, I'm going to come back to this. Most of this data is in the 60 to 90 minutes. There's very little data from these organized clinical trials that looked at the first golden hour, and that's where the ambulance becomes very important. Right, so what is the evidence supporting Telestroke? Well, there's plenty of evidence, and I'll show you some meta-analysis and guidelines. But before I go there, let me tell you where it can be used, and it can be used very effectively. So traditional, and we've been using it for more than 20 years now, we manage acute stroke and TIA consultations. This keeps us very busy. In fact, a third of our current stroke work is on Telestroke, both for management, but more and more commonly, we're also evaluating imaging, where we can say, well, this patient doesn't need to be admitted to hospital, they can be sent home, etc. And thrombolysis is common. And we also select patients who may stay for TPA at that hospital, or may potentially bypass and be sent if they have large arterial occlusion. In the US and in Europe now, there are actually the centers, they are virtual centers. So they're not sitting in a hospital like us, but they're sitting at home sometimes and managing 15, 20, 30 hospitals through a dedicated stroke Telestroke center. This is becoming very popular these days. Also, we've used the Telestroke for our stroke clinic for years now. At least 20% of our patients that we see are seen where the nurse is sitting with the patient. They could be 1,000 kilometers away, and we see their images and we manage them. During this COVID pandemic, our group and others now are using the Telestroke essentially to make stroke rounds now. So you go from patient to patient, discuss their care with the nurse present there. And finally, there's the whole question of mobile stroke units. So the rationale is very simple. Expertise is not widely available at smaller hospitals. And in the situation where they have a CT scanner and they've got a good competent ER, there is no reason for those patients to be transferred. It's also important in larger. So Saudi is a good example. Saudi Arabia is a good example. Alberta's size is that of France. It's huge. And we only have 2 tertiary care centers. So transfer delays can cause tissue damage. So we just treat them at their local hospitals. So as Dr. Al-Zahrani mentioned, I enjoyed your presentation going back to 1950s and 60s. So this was the first application. We do it in a setup technically from British Columbia to Newfoundland is more than 5,000 kilometers. So, you can go out and treat the patient from any distances. There is now, so it's 3,000 miles there. There's now very good data, recent meta-analysis that compares the safety of telestroke to in-person treatment. So the outcomes, whether it's improvement in care or the risk of hemorrhage, is more or less the same. So if you look at these studies, it's virtually identical. We have recently been looking at our provincial data from several years to see whether the risk of treating mimics increases in telestroke centers. So mimics are those patients who actually do not have a stroke, but may have symptoms that could confuse you. So there's a marginally statistically increased risk of treating mimics in your telestroke sites, but it's a very small difference. We haven't published that data as yet. So when we talk about the quality, here's a statement from the American Heart Association. One of the most frequently used and rapidly expanding application of telemedicine is telestroke. These are the best Canadian guidelines. We also agree that treatment of appropriate patients with acute therapies is safe and it can be done very safely and quickly. So it's a standard of care. So what's our data? So I thought I'll share some of that with you. In Alberta, our province is huge. This is the size of our province. We started a long time ago. So our initial centers were in 2005. Here's our city, and we were treating patients 500 kilometers away in a small town called Grand Prairie, and this town which is midway between Calgary and Edmonton. And so all these patients were being treated from our center. But in 2010, we had gone up to 16 centers. And some of these, if you look at some of these, so this center up in high level is more than 1,000 kilometers from us. So where are we right now? So most of these are referred to us in Edmonton. Where are we right now? We've got 2 comprehensive centers, 26 primary centers. Private centers, emergency departments are mostly staffed by family doctors. And these are not, if they're candidates for endovascular therapy, they're referred to us. In addition to these sites that have CT scanners, there are 78 other hospitals where they connect with us on Telestroke, and we can either direct them to one of these primary stroke centers or they can be sent into us. So it's a fairly complex setup. So out of, this is 2 years ago, out of 650 thrombectomies done in the province, more than 200 were done at these local centers. So for us in Edmonton, to give you an example, that center that I mentioned earlier, which is the Red Deer Center, 64 thrombolysis were done there. Queen Elizabeth is in Grand Prairie. So these are 2 of our bigger centers. And I'm giving you the populations down there. Also, the population of Red Deer is less than 100,000 people. So we treated more than 64 patients there, and then smaller centers with smaller number of patients. So we are very efficient at this. We get these patients treated literally in 35, 40 minutes from onset. And one of the things that's really interesting is that these hospitals are very excited about it. They get to speak to a consultant. The consultant looks at the images with them. And unlike our emergency department, where you may have 300 patients with multiple different conditions, these smaller hospitals can focus on those patients very well. So the second part, and I'll be done hopefully in the next 5 minutes, is on telestroke and mobile stroke unit. We were very interested. In fact, we could have been the first center in the world, but we weren't because some government issues with us. But anyhow, we got our stroke mobile unit about 4 years ago. So these are the guys ahead of us. Cleveland, his program is run by one of our ex-fellows. He would always show off. Houston is Jim Groters. He was one of the first ones. And these 2 in Germany. So Berlin has done most of the really seminal work. Here's our University of Alberta ambulance, one of our stroke fellows standing with it. And I've sat in this ambulance more than 100 times and treated patients with acute stroke. This is something that's going to happen in many places. They're popping up all over Europe and North America. In fact, there's more than 30 centers in North America. When I was in Doha, we had gotten the funding for it. We had actually bought the equipment also, but when I left, unfortunately, they canceled it. I think it's a big mistake, but hopefully in Saudi or in some of the other Gulf countries, they will bring it in. I'll tell you why it's so important in my next slide. So our catchment area, here's Edmonton. Our catchment area is 250 kilometers out. A lot of our imaging and treatment is done in the city, but we go all the way out to 250 kilometers. So remember at the start, I said that 1 in 3.5 to 4 patients, 1 in 4 make a full recovery in the first 90 minutes. But the data is very interesting. That's mostly in the 60 to 90 minutes. The first 1 hour, the data was not very clean. So the Germans are the first ones who showed that if you compare the standard of care, you can see very few patients make it to treatment in the first hour, first golden hour. So this is the standard of care in Berlin, which is one of the best centers in the world for very quick treatments. Compare this to when the ambulance is treating patients. So here's patients being treated in the stroke ambulance. So the vast majority of them are being treated within 30 minutes to 60 minutes. So what does that translate into? So I'm ending my presentation. So pay attention now. This is the most important part of my presentation on why these ambulances are so important. Take 100 patients with an acute stroke. And if you're asked the question, how many of them would make a good recovery if you don't treat them? So the number is 26. So 26 patients out of 100 patients, if you don't treat them at all, would make a good recovery. Now, if you treated these patients with TPA in the 4.5 hour time window, which is what the standard of care is, you'll see that an additional 7%, so that's these 7 individuals, would make a good recovery if you treat them within 4.5 hours. Now, if you move that to treatment within 90 minutes, that number increases from 33% to 48%. So clearly time sensitive. Now, what about if you treat them in 1 hour? And this is where I wanted to focus my attention for you. That number increases from 48% to 68%. This is randomized trial data. This is very good data and was presented and published in the New England Medical Journal. It was first reported on September 9, and you can see that this is your standard of care, and this is your standard of care so 0 or 1 on the modified Rankin scale is a full recovery. So you can see how efficient it is. It is expensive. Our unit cost $700,000. They're now running into $1.5 million, but the technology has improved. The CT scan not only can differentiate between a hemorrhage or an ischemic stroke, but you can do CT perfusion imaging. You can actually do CT angiograms, which can help move this patient to the designated comprehensive center much more quickly. My last slide in here is on COVID and Telestroke. So because we had restriction of patients during the pandemic, there's been a big increase in the utilization of telemedicine. We were at one point seeing almost 100% of our patients in the clinic through Zoom and telemedicine. And as I mentioned also, that now we are routinely using Telestroke in admitted stroke patients, especially if there's a ward where there's a restriction because of increasing numbers of COVID cases. So my final slide, I hope I've convinced you. I think it was great to have Dr. Al-Zawani first talk about it. So there is extensive evidence now that Telestroke is as good as in-person treatment of acute stroke. It helps us treat patients at smaller centers where the expertise may not be available. And we are certainly using it in these areas much more frequently. We're also expanding our use in the clinical management when it comes to consultation in clinic, as well as in management of our patients on the ward. So I thank you for your attention. I think I've been within my 20 minutes.
You are within the time frame allocated to your lecture. Thank you very much for a very nice presentation. And I like the last few slides that showed the benefit of the mobile stroke unit. We'll move to our final presentation. It will be presented by Dr. Fahad Al-Ajlan. He's a consultant vascular neurologist at King Faisal Specialist Hospital and Research Center in Riyadh, and an assistant professor at College of Medicine in Al Faisal University in Riyadh too. He's the director of the newly established stroke fellowship program there, and he's a member of the American Academy of Neurology and the Stroke Saudi Association. Fahad's interests in research include acute stroke and neuroimaging of acute stroke. Fahad will be talking about stroke patient optimization. Fahad.
Hi, good evening, everyone. I don't know if you can hear me very well. I'm sorry for the technical problem.
Yeah, we hear you well, Fahad.
Yeah, sorry. I thought that Saeed and Ashfaq will cover the topic very well and will leave nothing for me. So I thought about why I don't share with you a book, and so I can do something something nice on the next 15 minutes or so. So I went through this book, and I want to take you through it on the next 50 minutes or so. It's a book called Good to Great by Jim Collins and his colleagues. What they did in this book is that they went, I will read first the first sentence from the book, which said that greatness is not a function of circumstances. Greatness, as it turns out, is largely a matter of conscious choice. So they went into...
the slide is not moving, Dr. Fahad. It's in the first slide.
I will end the show, new share. What about now?
Yes.
Okay, perfect. So what Jim Collins and his colleague did, they spent 10.5 years researching for 11 publicly traded companies who went from good to great at this point. By great, we mean that they outperformed their company of comparison by 3 times or more. And to determine this issue, they went to a company in the same industry, similar size, with access to the same resources, but failed to outperform the market. And they found 3 interesting concepts. One is the Hitchhike Concept. So as you know, the fox knows many things, but the hedgehog saw only one thing, one big thing. And this is from an ancient Greek parable. So if you see that every day when the fox is trying to go from his home to hunt his food on a daily basis, the fox will try each day a new trick to trying to catch the hedgehog. Nevertheless, the hedgehog only one trick. So he will turn into a spheroid structure where there is a lot of fox around him, and every time the fox will fail to catch him. So by using a simple but effective strategy, every time the hedgehog wins over the smart fox who's using many tricks. So that's one of the things that we need to learn when we are optimizing the stroke care for the patient. And I believe this comes from the pre-hospital stroke. If we optimize it and use this simple concept, I think we will beat a bad system or a different presentation every day. We have different type of pre-hospital system. Saeed and Ashfaq covered this very well, but I think at least if you don't have the fancy mobile stroke unit, at least you should have a telephone consultation within the field where you know what kind of patient you are expecting. It will be great if you can have, with the modern technology that we have right now, a 4 or 5G video consultation. The second thing that is you apply the same thing, which is the hedgehog mentality, is that you define and pre-specify and rehearse your workflow for acute stroke treatment. So every patient, when he comes to the hospital, we know that he will go through triage to ED room, nurses, stroke team, INR if needed, and to the stroke unit. Everyone should be prepared knowing his responsibility. So the best way to beat that is by doing the checklist. And I believe the checklist here is resembling the Hitchhike mentality, where you have something, you apply it in every patient and you never bend the rule. The second part is that we need to do what we learned from the formula, where we do the lean stop. What I mean by that is that we go in a parallel processes. So somebody is working on one thing, but we are not going sequential. The second thing that I want to stress on is that we need to be simple but effective. So when the patients come to the emergency, one of the things that need to be determined is last seen normal and grossly the NIH stroke scale, but should not intervene with your time heavily. Establishing IV lines, going to the CT scan and having a capillary glucose is the must, as well as the vital. The next thing is you need to go to the images. This is an acronym that if you want to remember, which calls critical, that you call the stroke code after, you register the patient, you initiate the order, transport immediately to the CT scan, identify a patient with a wristband, and definitely a glucose check, assess the weight, and start scanning. TPA, as my colleagues clearly alluded, that time is brain. It is the full clot destroyer that we use to open up arteries. So your triage nurse should be, a rule should be very simple. Identify the patient and register him. Place the name band on the patient, IV lines, weight the patient if possible, or you have the bed scale, draw labs, and go to the CT scan. Back to Jim's column book, where you can go from good to great. The next thing is you have to have the bus theory. Basically, in your team, you should know who should be in the team and where to sit your team. What do I mean by this? This is your stroke team, which consistent of many members. So you should have your senior resident or fellow as being the team leader, where he is the treatment decision maker. Your junior resident is the one who's taking the history and the consent. Your junior resident 2 is the one who is doing the exam and he's always with the patient. Your intern doing the chart review. And your emergency doctor in the middle of the night, if the patient is coming and there is no pre-notification, should make sure it's a stroke, it's a hyperacute stroke within the window, make sure that the patient is stable, and lead the stroke team until the team arrive. We need to order a CT scan because this is the way to differentiate ischemic from hemorrhagic stroke. Then you go and decide what type of ischemic stroke we are dealing with, early window, late window, how much is the aspect. And I believe that the team should meet, the 4 team members should meet on the CT scanner to make the decision. Always we transport the patient with a bed monitor that is mobile. One thing I would advise your team to have is the stroke box that is located in the emergency department, and it's consistent of these things: alteplase, anti-emetic, antihypertensive, anti-epileptic, syringes and needle needed for IV, TPA, intubation kit if your emergency is far away from your CT scan, and TPA order set and dose charting. So after establishing this at the team meeting on the CT scan, make sure that the blood pressure is okay. If he's for TPA, you go for TPA. Consent is something depend on your geography and your hospital setting. One of the things that I would advise too is using the visual tool for patient and their families, because sometimes they will not understand what is the number needed to treat or what is the risk reduction or absolute risk reduction. It's applied for both IV TPA and mechanical thrombectomy. This is the dosing chart, will facilitate things and improve speed. The second thing is having an order set of the patient already prepared, where you don't need to go for any details, everything prepared. If your hospital is using a digital healthcare system, you can implement it. If you are still using the paper, also you can use it. You can see here in our system, we are even specifying the angioedema treatment if the patient develops side effect from TPA, the reversal of the hemorrhage, The consent written specifically for IV thrombolysis in both language, Arabic and English, and also depending on your country. So as I said, and the CT team will meet and make the decision. Remember, the stroke is a clinical diagnosis, and for IV TPA, all what we need is the CT to rule out hemorrhage. So in regard to IV TPA administration, we are a big believer of programming the IV TPA pump before doing the CT scan, because if the patient turned out to have a hemorrhage, you lost nothing by programming the pump. But if he's candidate for IV alteplase, probably you save 3 to 5 minutes, and you will mix the IV TPA while the patient doing the CTA. Because you know that the CTA probably will take mixing the drug will take 2 to 3 minutes. By that time, patient will complete his CTA. You don't need to wait for your creatinine. One of my mentors told me that neurons over nephrons. If you go back in history and read this work by Eti Mirtoja and his colleague, what they did exactly is that they apply those principles of Jim Collins' good to great. And they were able to achieve a 20-minute. I think in a realistic life, if you don't have a lot of pre-notification, 30 minutes should be your goal. That's what they did exactly. They started the pre-hospital notification, no delay in CT interpretation. The CT were reallocated in the emergency, a rapid neurological examination. You didn't need an accurate, detailed NIH, and point of care INR if needed. Pre-acquisition of history before arrival, reduce imaging time, and there is something called learning by doing, which I do believe in it a lot. And by the end, they ended up having almost all of their patient less than 30 minutes. If you do CTA for all, I think it will reduce time to mechanical thrombectomy initiation. And if you mix the drug while the patient doing the CT scan, I don't think this will delay the TPA administration. CT perfusion is something that we use in our hospital, and that I think will promote IV thrombolysis, especially after working hours, or if you are using a telestroke. So I do believe in the 30-60 rule, where from the CT scan to the administration of drug, it should be 30 minutes, door to IV TPA, and from door to groin puncture, it should be 60 minutes, and door to first reperfusion, it should be 90 minutes. The third role that I want to emphasize on it at the end, it's depend on leaders. You need to have the leader who is going to transition from being a highly capable individual to contributing team member, improving to be a competent manager. Then after that, he is an effective leader, ending up by being a true executive by building and enduring greatness through a paradoxical blend between personal humility and professional will. This will work with time. Probably if you read the book, you will understand this from the flywheel idea. I remember learning this during training, where we reduced the door to needle to 8 minutes. You need to collaborate internally, externally, having flexible goals, focused goals, collaborate, create your own system, compete with yourself and your colleagues, and control your environment, because you cannot do it without a control system. Remember, this is Dr. Ashfaq Shaib showed this very nicely, so I will not reduce it, but our number needed to treat will be reduced to 3 to 4 hours. Remember that our colleagues in cardiology, their number needed to treat is 17, and this is taken from their guidelines itself in their executive summary. This is our telestroke pathway. I think having the Hitchhike mentality, doing things in parallel, as you can see, helped us to achieve this data. This is this manuscript in preparation. This is the 2 years telestroke program, where we ended up by giving 59 IV TPA, 59 mechanical thrombectomy, 94 IV thrombolysis, and provided more than 1,500 telestroke consultation. My last slide, I would say that great. This is again from the book Good to Great, that great vision without great people is irrelevant. With that, I think I'll end up my slides.
Thank you, Fahad, very much for a very nice overview of how to make the flow of patient care in acute stroke seamless, aiming to reduce the time from arrival to administration of thrombolysis. And I like your slide where you showed that you have to be flexible and you have to be creative, and you do things that would fit your own system. I'd like to again thank all the speakers, and we will open the discussion. I'd like people to send their question to the Q&A box, and we'll go over it based on first come, first answered. Before we go there, I have a question to all the speakers, starting with Saeed. With regard to the TCD-based and the electromagnetic radiofrequency techniques that you have shown, were these tested by clinical trials, or what you have shown is some work that was done by the manufacturer of these devices?
Yes, thank you for asking these important questions, Dr. Abdurrahman. The radio frequency, as I mentioned, is still in the pipeline, so it's a disruptive innovation. It's been tested now in large trials in Australia, so we are waiting for the trial. But I just showed the next innovation in stroke care.
And what about the TCD-based techniques?
TCD is as well. It's not yet tested in trials. Mm-hmm. It's been shown to augment the pre-hospital pathway, but it's not very still not very reliable in the pre-hospital stage, especially if you want to judge whether to receive TPA or not. But in terms of triaging patients to primary stroke center or comprehensive stroke center, it can help to augment the clinical or the pre-hospital clinical scales measures.
Okay, thank you very much. Question to Ashfa, with regard to the mobile stroke units, could it be applied everywhere in the world?
Yes, it's an excellent question. Take the example of Berlin. Berlin has 16 stroke units. It's by law the ambulance has to be at the place where the emergency is activated within 16 minutes. So their ambulance services are very good. Despite that, they now have shown very clearly that they can get to the patient and treat them within half an hour to 45 minutes in more than half their cases. In fact, the program is so successful that they've got 4 stroke ambulances now. In other places, like we were thinking of it in Qatar for a simple reason that Qatar is like an island. Doha has the stroke center. We had started a stroke program in Al Khobar, which is about 110 kilometers away, but it left the entire country otherwise out of reach, both because there wasn't enough imaging and there wasn't enough expertise. So the ambulance would go out. I mean, we routinely send the ambulance out 2.5 hours, 3 hours out. We treat them in the middle of nowhere, basically. So a short answer, yes, as long as you have the resources, and it is expensive. As long as you have the resources, and there is the connectivity, the internet connectivity, you can use it anywhere. They're using it in Thailand. They're using it in southern India. So many other places too.
Okay, thank you. And for Fahad, with regards to people working in parallel when it comes to acute stroke management, beside giving members of the team written instructions, do you think there is a role for doing a mock codes where the team will just do it again and again on a member or a nurse so that they improve their workflow? Do you think that's something that can be done? And could that be also used for training purposes of people who are joining stroke medicine?
Yeah, thank you so much, Abdurrahman. This is a great question. I think there is a rule for mock codes and stroke simulation courses where we simulate codes, because sometimes people are not familiar with the idea of the code and working in parallel instead of sequential. One of the things that already has been done, and I think it's something that each center should have, is if they have a simulation center, having a stroke code course or stroke code team simulation will be of great value to them.
Thank you, Fahad. I have a few questions from the audience, and we have over 1,100 people. The first one came at 7:30 from Ibrahim Eid, and he did not address it to any member, but anyone can take that. He said, what is the treatment of stroke 1 month after the onset? Dr. Shuaib?
Yeah, it's the best way of looking at that is what is the risk of another stroke? So if you've had a stroke that's 1 month out, there's 2 or 3 things you can do. So one is enhancing recovery for this stroke, the current stroke. Patients are fatigued, a third of the patients are depressed, and so you've got to focus on that, because a depressed patient is not motivated. A fatigued patient is not motivated. There's plenty of evidence that if you're going to improve and enhance recovery, you need to have therapy. So watch for depression and fatigue. Encourage therapy, because that is going to promote recovery. So you're no longer in the phase of preventing damage. Whatever damage has already happened, it happens in the first day or so. So one, you want to enhance recovery. And second, extremely important, very important, after the first patient, after the first stroke, many patients actually do well. They go home, but they're at a very high risk for a second stroke. The risk of a second stroke is 10 times higher than any other person their age in the population. So our focus.
Yeah. So the idea is rehabilitation for those people who can be rehabilitated, and to stick to the secondary prevention strategies that were developed by the stroke neurologist in terms of modification risk factors and antithrombotic agents.
Thank you.
The second question is from Muhammad Munir Khan. And his question is that are there any courses in stroke medicine and telestroke, and it has to be of short duration, where we can learn the tactics and apply it in our areas? Dr. Saeed?
Yes, so there are a few courses online on stroke treatment. So one of the platform is the World Stroke Academy platform that you can go and log in. There are many webinars and stroke courses. The Angel Initiative as well, they have courses online that you can log in and register, and they would certify you for completions of that stroke. We have in Saudi Stroke Society, we have the Stroke Academy as well, that you can go and educate yourself on stroke. There are, I think, 2 conferences already uploaded there on the Saudi Stroke Academy for physician, for nurses, and for physiotherapists as well.
Okay. Thank you. Next is an appreciation words from Dr. Tariq Al-Afifi to Dr. Shuaib for starting Edmonton Telestroke. We'll move on. There's a question from Wael Al-Wachi. He said, if possible, how can I get a chart for acute stroke management? And is it possible to upload? Dr. Fahad?
Sure, I think we can share it with the organizers. We have no problem with that.
Okay. All right, next is a question from Latha Raj. He said, if a child is epileptic and cured, is there a chance for him to get strokes as adults? Dr. Shuaib?
That's a good question. So there is a slight increase in stroke in patients who have epilepsy, and it's mostly risk factors. They just tend to have more risk factors. So as long as you can avoid risk factors, your risk should be no higher than anyone else.
Okay. All right. Next question is by Mariam Riham. Which modality is more preferable in stroke, CT scan or MRI, and why? Why is that? Dr. Saeed?
So in the acute stroke, we prefer the CT because it takes shorter time to do. You can calculate your aspect score and see if there is a contraindications for thrombolysis. And the important things actually in the acute stroke is to rule out hemorrhage, which can be done easily by CT scan. MRI in the acute stroke, it takes time to do. Sometimes it may confuse you, especially if you have a posterior circulation stroke and you did the MRI looking for diffusion. And then even sometimes if you find the diffusion restriction, you would say this is an already established stroke or there is an increased area. So I would prefer a CT scan in the emergency room, the emergency cases of stroke.
Okay, thank you. Another question from Wa'il Al-Wahji. He says, in Libya, we don't have a stroke center. How can we establish a stroke center, and what is required in terms of tool to provide such very important service? Fahad?
We appreciate these difficulties in some of the countries and healthcare system. But I think there is three things I would call it the most important things. Number one is the willingness from the team and administration. Number two is the leader from the stroke team. And number three is the basic resources that you need for that. I mean, really the basic resources. We don't need to have a fancy stroke unit. Probably if you allocate a couple of beds, train the nurses, and put some designated bed, probably in the same place, and you could call this a stroke unit because that's basically what is it.
Okay, thank you, Fahad. Question from an anonymous attendee. He said, how to reduce severe spasm in chronic stroke cases? Therapy doesn't work, and medicine, baclofen, etc., reduce BP and overall consciousness of patients. So Dr. Shuaib, it's regarding the severe spasm that happened after a stroke.
So it's a good question. We as acute stroke neurologists don't deal with it personally, but I understand that our colleagues in rehab medicine are using Botox quite a lot and seem to be effective, and is a very popular option because the spasms are mostly increase in tone, and they can be very painful. But why don't we ask Fahad or Saeed, because they may have more experience.
Saeed or Fahad, if you have a word to add with regard to treatment of severe spasms.
So I would prefer to use the Botox, especially in the stage 3 of recovery or stage 2. So earlier on using Botox, once the spasticity starts to improve, that will result in a better outcome for the spasticity. For the spasm post-stroke, baclofen maybe help, or gabapentin.
Okay, Fahad, anything to add with regard to spasm treatment?
No, just probably adding the other treatment that can be used for spasm if Botox is not available in some of the country, like tizanidine and such medication.
Okay, and the questions, I think they have changed because I'm missing the flow of the questions. The organizer, did you omit anything? because it was working well. All
No,
right, so
doctor, still the questions are there.
Mm.
What we did is already answered questions has been moved to answered. That's it. The remaining questions are unanswered.
Okay. So a question from Mohan Chandran. How does stroke have a seasonal occurrence so that we can anticipate its occurrence? Dr. Fahad?
Yeah, that's a great question, Abdurrahman. I don't know about other community, probably maybe Ashfaq can speak about it, but this is something personally I'm interested in, which is the effect of Ramadan and Eid on ischemic stroke. I do believe that ischemic and hemorrhagic strokes tend to have a higher increase in Ramadan, probably due to the disturbance of the medication and due to the dehydration. And also, I think there is a seasonal peak for cerebral venous thrombosis in our region. Here, I'm speaking in our region because of the summer effect, where the degrees, we go up to 45 or 50 degrees. But maybe Ashfaq can go. He's in Alberta. I know how does it feel in Alberta. So probably Ashfaq can share.
Does the cold have an effect on the stroke occurrence?
Yeah, so a very quick answer here. When I was in Qatar, we looked at 4 years summer-winter variance. We actually published that paper. If anyone's interested, we can share a copy with you. There's about a 12% increase in stroke in the summer months, and we believe it's because of the extreme increase in the temperatures, the 50+ degrees, as well as changes in barometric pressures. This is despite the fact that the population actually shrinks because a lot of people go on summer holidays. There's been a recent meta-analysis also. So most of this work comes from the Middle East, from Qatar, and I just recently reviewed a paper from Saudi Arabia also. And there's some work from Israel too, stating that in extremes of temperature, I think the point that Fahad just make is a correct one, that they're probably dehydrated, and Ramadan only amplifies that.
And is that what you're referring to, the increase during summertime? Is it the venous or arterial strokes?
Oh, so those are arterial strokes. We looked at arterial strokes and hemorrhages, but it was in fact the arterial strokes that increased during summer.
Interesting, and a very good question indeed. Another questions from Mahmoud Al-Momani. He said, how can we distinguish between hemorrhagic stroke and ischemic stroke in pre-hospital care? Dr. Saeed?
So the definite way to distinguish is in the pre-hospital setting is the mobile stroke unit where they did the CT scan. The other way of distinguishing between ischemic and hemorrhagic stroke is still in the infancy. So by doing the transcranial Doppler or the VIS scan, that can help in distinguishing both in terms of triaging, not in terms of medicating people in the pre-hospital stage.
Are there any clinical hints that might point to hemorrhagic versus ischemic? For example, severe headache or double vision or other things?
So, yeah, and in several studies, they did not find any clinical criteria that may distinguish stroke or ischemic stroke from hemorrhagic stroke. So there are, as you mentioned, if you have severe headache or nauseated in the early vomiting, it may hint toward hemorrhagic stroke, but it's not very specific, or it's not a sensitive score.
All right, we'll move on. A question from Moido. He said, is obesity and smoking increased chance of stroke? Fahad?
Yes, I think that's a good question. I think the short answer for this, yes. But also there is factors that have to play on a personal level.
Okay. So I think obesity is usually associated with other risk factors like hyperlipidemia and sometimes hypertension, and smoking definitely is a risk factor for stroke. Another question from the same attendees. Is there any prevention before the stroke happens? What can we do to avoid stroke from happening? Dr. Saeed?
Yeah, so there are primary prevention, so that's before the stroke happening, which is controlling the vascular risk factors. If you have high blood pressure, diabetes, if you are smoking, you need to quit smoking. You have to, if you are obese, decrease your body weight, do exercise frequently, at least 30 minutes, 5 times per week. That's before you have stroke. This is a primary preventive strategy. Aspirin in primary prevention did not show any benefits. While after a stroke, it will depend on the cause of stroke that needs to be investigated to prevent its recurrence.
Okay, thank you. A question from anonymous attendee. How would you please share how many facilities are using Telestroke in the Kingdom of Saudi Arabia? Fahad?
I don't know the right number accurately, but probably Saeed can fill the gaps here because he's leading this program on the national level. But I think in the private practice, there is 6 hospitals who have a comprehensive stroke networks, and there is around, correct me, Saeed, 20 hospitals already connected to the national network.
Yes, so there are now currently 7 hospitals already connected to the national network. In the pipeline, there are another 30 hospitals will be connected from around the kingdom, inshallah.
And these 7 hospitals are fully operational when it comes to stroke treatment?
Yes.
Very good.
So we had our training to the site. We did several mock tests to improve their performance in terms of stroke code. We provided them with the policies, the procedures, the guidelines, the protocol for TPA, and we did the 24 hours follow-up as well as a part of the quality measurements and the 3 months follow-up.
Okay, thank you. Another question from Venkata. How often do you come across monoplegia as a manifestation of stroke, and how do we manage that? Ashfaq?
Yeah, a very good question. So basically, when you think of stroke, it's which vascular territory is affected. So if you have a partial middle cerebral artery occlusion, you would see an arm involvement only. It confuses you because sometimes you miss those patients as having a stroke, but you treat them exactly the same way as you treat any other stroke.
Mm-hmm. Another question, how important is it to have an interventional radiologist or a neurosurgeon available in a stroke center? Is it a high risk setup for having a stroke unit without either of those? Dr. Fahad?
That's a great question. I think it's depend on your classification as a stroke center. If you are a primary stroke center, you don't need them. But if you are a comprehensive stroke center, I think you need both of them. But if you don't have them, does not mean that you should not provide the service. You could collaborate with other centers where you provide the service that you can provide and then ship the patient to the facility with the higher equipment and higher staff.
So you need them. They don't have necessarily to be available in your place, but you should have access to them whenever you need them. Somebody with hemorrhage after TPA, for example. So you need somebody to take care of that.
Sure.
Okay. So another question, in cases of stroke due to small vessel disease with liver cirrhosis, which antiplatelets can I choose in case of compensated or decompensated liver cirrhosis? And if the liver cirrhosis with cardioembolic cirrhosis, maybe cardioembolic stroke with MCA occlusion, if it's valvular or non-valvular AFib, also in case of compensated or decompensated liver cirrhosis. So what is the best strategy in the 4 previous clinical scenario? My question is Dr. Shuaib. So Dr. Shuaib, so with regard to stroke due to small vessel disease with liver cirrhosis, which antiplatelets should we use?
Yeah, it's, aspirin is a good one. I'm not clear about the question though. Is this small vessel disease pre-existing on imaging, or somebody's had a lacunar stroke?
So not clear from the question.
But if it's a lacunar stroke, you keep the person on aspirin, but very importantly, manage their blood pressure and their diabetes. That's how you prevent another stroke.
Mm-hmm. And if this was related to AFib, if it's cardioembolic stroke and the patient have liver cirrhosis, which medication do you choose?
That's a very good question. I don't know the right answer. I mean, we are probably going to use one of the new oral anticoagulants, but I would definitely get a hepatologist involved. And they're the ones who guide us in such cases.
Yeah, I think for non-valvular AFib, the DOACs are good options, unless the patient is really having decompensated liver cirrhosis. And for valvular, it's warfarin. Again, you have to look at the liver. As you said, getting a hepatologist involved is important.
I agree.
All right, we'll move on. Question from Suad Ramadan. What is the best anti-epileptic treatment for secondary epilepsy, probably secondary from stroke? Dr. Saeed?
So you would treat it as you treat other epileptic patients. So that if it's secondary to stroke, most likely would be a partial seizure. So we would choose medications that treat a partial seizure, not the medication that is for generalized seizures.
Could you give an example of a medication that you would use in acute epilepsy?
So I would use Lamictal or carbamazepine, levetiracetam as the primary choice, or lacosamide.
Fahad, do you have any words on acute epilepsy from stroke?
I tend to give it according to the patient profile rather than having one agent in particular. Depend on the patient profile, but I tend to stay away from the medication that used for generalized epilepsy, especially valproic acid, because it's affect the platelet function.
Okay. I think we have now reached to the end of this webinar. We have other questions. We will not be able to answer them. I would like to thank all the speakers, Saeed, Ashfaq, and Fahad, for their impressive insight and for their beautiful presentations and for their time. And I would like to thank all the attendees and for all their questions. This was a very enlightening session, and we learned a lot from our speakers. I would like to thank the organizers and the MENA Stroke organization for arranging this activity. With that, we will conclude, and I would wish you a happy and blessed Ramadan, and we'll see you inshallah in the next webinar.